This is module 3. We're going to talk about diagnosis of postpartum hemorrhage, specifically recognition and ideally early recognition. Components of recognition that I wanted to highlight are what you would do to screen and assess women who are coming in to deliver, what you might do to decrease their risk of hemorrhage. Specifically, if hemorrhage is occurring, thinking about things that will help the care, meaning measurement of the cumulative blood loss in as much of a quantitative manner as can be done, actively managing the third stage of labor or the delivery of the placenta, and paying very close and repeated attention to the patient's vitals. So, there's a variety of risk factors and causes for maternal hemorrhage. I have them listed there. It turns out in the majority of cases, postpartum hemorrhage is from atony, meaning after delivery, the uterus is unable to tighten back up and continues to bleed, as well as another cause, which is retained products of conception within the uterus, which sort of prevent it from contracting down and decreasing the bleeding. I would divide the causes up here into two parts. I didn't unfortunately do it nicely by column, but you have causes that are known ahead of time before the woman goes into labor, such as the location of her placenta. If she has a previa, potentially is at risk for an accreta, which means the placenta is not only over the os, which is the definition of a previa or the opening, but in an accreta, there's an abnormal adherence of the placenta to the wall of the uterus. These items can often be known ahead of time, and patients who had a previa and have a history of multiple prior cesarean sections or have a high likelihood, and therefore, a high likelihood of accreta, may either want to be moved to a more high-level care institution or undergo further imaging to try to determine their risk. Patients with known coagulopathy, large tumors like myomas, obesity, multiple gestations, meaning twins or triplets, history of cesarean delivery or history of a prior postpartum hemorrhage are all at some degree of increased risk by association, and a discussion among their primary healthcare provider and other physicians involved in their care should occur to determine what might be the best location for their care as well as the best approach. Other causes occur during labor. You can have abruptions where there's bleeding behind the placenta, between the placenta and the wall of the uterus, a rupture of the uterus, an inversion of the uterus as the placenta is being delivered, having an induction or a large child also put you at increased risk for hemorrhage. And as I said, uterine atony is probably the primary cause out there for postpartum bleeding. And the risks for uterine atony sort of mirror and overlap what I showed you on the prior slide. And you can see them there. These are mostly occurring around the time of labor and delivery, but people should be aware of them to know the patient's risk as they progress in labor. This is a table that allows the healthcare providers to think about the risk of postpartum hemorrhage for each patient. This one happened to be put out by the California Collaborative. But you can see there we have definitions and examples of low risk, medium, and high risk. They also talk about what you would want to do regarding blood products, whether you need to type in screen or type in cross match, and blood readily available. So you can see low risk there, no history of prior bleeding, a singleton pregnancy, no real issues, up to high risk where they have a previa or maybe suspected accreta. They're starting out with some anemia or a low hematocrit, chance of coagulopathy, such as low platelets or active bleeding, and sort of the gamut in between. I think the biggest benefit of this table is just to stimulate a discussion between the care providers and to think about every single patient that is admitted to labor and delivery. There's a variety of other tables which have similar ideas on them. Let's talk a little bit about ongoing blood loss and ways to quantify that blood loss more than just estimate it. So one way is to use graduated collection containers at the time of delivery, either vaginal or cesarean delivery, and making a mark on the container after the amniotic fluid has been placed in the container by a suction, so that you know after that point everything is maternal blood. Sometimes for vaginal deliveries, under buttock drapes are used so that the bleeding can be more easily quantified. Weighing also has been used effectively, where you have the known weights of different pads or laps or sponges, and you weigh them after they've been used to clean up maternal blood, and the difference in the weight between the initial object and after it's been soaked can be determined and help you quantitate the blood loss. And then finally, if you don't use weighing, you can have training tools such as posters that show approximations of volume in sponges or pads and what each of those means. I would advise doing this specific to your own institution with the sponges and pads that you use, and taking pictures to show what different volumes of blood look like on these objects. Again, I think a lot of these do certain things to help improve the maternal care. One, it calls for periodic reassessment of the blood loss so that people are attempting to quantify it. I think it helps get rid of denial and improves communication, where actual amounts of blood can be transmitted to the various care providers as they're coming in to assist with the care of the mother. And it's much, much better than not having a system at all. Whatever you do, whatever one of these tools you try to implement, I think it's much better than just not doing anything. The sort of final part I want to talk about on this module is looking at vital signs and hemodynamic changes. Now, the physiology of pregnancy tends to make it difficult to interpret some of the vital signs changes for those care providers who don't routinely manage patients on labor and delivery. There's a compensatory ability of the mother to maintain her cardiac output with an increase in heart rate initially in the early parts of hemorrhage. Consequently, the patient's blood pressure is often also maintained until things become very bad. And this is done through not only an increase in heart rate, but also an increase in the tone of the vessels or vascular resistance. And so consequently, what's often seen is the decrease in blood pressure secondary to hemorrhage is often very, very late during the blood loss. And what you normally just see initially is an increase in heart rate. The other thing is these patients are very different in that most of them are very young, healthy women, and consequently they're able to maintain these high heart rates as opposed to other patients typical outside of labor and delivery that might be much more advanced in age and not be able to maintain these higher heart rates used to keep blood flowing to the vital organs during hemorrhage. This is an example of a modified early obstetric warning system. The abbreviation is MEOWS, and it is put out by the National Health Service in Great Britain. This is just an example here, and I don't necessarily expect you to be able to read it. I just want you to get the idea that frequently, the mother needs to be assessed frequently after delivery with a variety of vital signs looked at, from respiratory rate, oxygen saturation of the hemoglobin, temperature, heart rate, urine output, what the amniotic fluid looked like at birth, and neurologic assessment. And then these are filled in on a scale for each one. And if you end up, say, with one in the orange or red on this sheet, depending on how it's coming on your monitor, or two in one of the yellow rows, that there should be an escalation of care. Some specifics with these vital signs. Respiratory rate is actually the single most important parameter for early detection, sort of all maternal events that might result in eventual physiologic collapse. Oxygen saturation is important because it can also predict respiratory compromise in addition to the rate. When you do record it, though, it is important to note if the patient is on supplemental oxygen or not. I'd already alluded to heart rate being a key parameter. Tachycardia sometimes can be the only vital sign change we see early on in hemorrhage. Temperature can help tip you off to sepsis. And so putting all these together really forces the healthcare provider to look very objectively at each one of these vital signs and think about escalation of care, and also provides them for the reason of the escalation of care when they're communicating to the individual that they're consulting. This is just another example of how this early warning system can be tailored to an individual hospital. This is just an example that was used as in some of the hospitals in the National Health Service. And what they did was, instead of using sort of the one red or two yellow rows to escalate care, they specifically provided a scoring system. And then they had a flow diagram where if the score overall of those vital signs remained at 2 or less, they could continue on with their current care, but they had a plan for escalation of care as those numbers increased all the way up to 6 or greater, which then they would bring in sort of everyone possible to help with the care of the mother. They had some algorithms, as you see already on their flow sheet, and some early ways to intervene to improve the outcome of the mother. So again, just the idea that even taking this early warning system, you really want to take the time to think about how it's going to play out in your healthcare facility and what you can do to optimize the care of the patient at that institution. So thank you.